the ears, nose, and throat are intimately related, anatomically and functionally, and diseases presenting with symptoms of one part are often associated with abnormalities in another. For instance, secretory otitis media, or fluid in the middle ear cleft, may be caused by a tumor in the postnasal space, or chronic laryngitis may be due to mouth breathing because of nasal obstruction, and pain in the ear is sometimes referred from the piriform fossa of the laryngopharynx. Because of these relationships, almost any patient with symptoms referable to the ear, the nose, or the throat requires a formal, comprehensive examination of the component parts of all three systems. Examination of the ear, nose, and throat depends to a very large extent on visual inspection and the acquisition of skills which enable one to see into relatively inaccessible recesses and niches. Obviously, lighting is very important. This may be provided either by a traditional head mirror in association with a bulldog lamp, or by an electrically operated headlight. Now, either form, unlike an ordinary torch, illuminate coaxially with the line of vision, and both free the hands for manipulation of instruments. With all the inspections in ENT examination, only part of the field can be seen at any one time. Landmarks must be identified and a composite picture built by scanning and mentally superimposing the adjacent small views. Apart from light, special mirrors are needed to reflect the light into anatomical recesses and to provide a line of vision for observation. The instruments required for ENT examination are really quite simple. The techniques for their application are rather more difficult. First of all, then, let us look at examination of the mouth and the oropharynx. For this and all the other examination procedures, the patient's chair should be at the same height as that of the examiner, and the patient should be leaning slightly forwards. The only instrument needed is the lax tongue depressor. This is preferable to a flat wooden spatula because it provides some leverage on the tongue and the examiner's fingers don't obstruct the view. Now, if you can open wide. Looking into the mouth, one should inspect the buccal mucosa, the teeth, and the orifice of the duct of the parotid gland. When the tongue is raised, the openings of the submandibular ducts can also be seen. The patient is asked to lower her tongue, and the palate is inspected. Movement is demonstrated by asking the patient to say "ah." We can see the surface of the tongue, the tonsil, and the pillars of the fauces on each side. Finally, the posterior pharyngeal wall, right at the back, is inspected. Looking into the mouth in this way, conditions such as quinsy or a cancer of the palate, for example, can be demonstrated. Although large tonsils should be noted, it must be remembered that the size of the tonsils is more related to their anatomical situation between the pillars than to their actual bulk. Immediately above the oropharynx is the postnasal space. This is a very difficult area to examine and even in skilled hands, it is not always possible to obtain a good view. Because the area to be viewed is around a corner, a mirror 10 to 12 millimeters in diameter must be used. First of all, it is warmed by holding over the flame of the spirit lamp with the glass side down, and then the temperature is carefully tested against the hand. The patient's mouth opens, and the tongue is depressed with a lax tongue depressor, and the mirror gently introduced to view the region above the soft palate, which of course is the postnasal space. We can see here the eustachian orifice on the right side. And on the left. We can also see the back of the inferior turbinate, the back of the middle turbinate, the nasal cavity, and the nasal septum. Above the eustachian cushion is the fossa of Rosenmuller. A carcinoma of the postnasal space can be seen by this technique. Moving down then, we reach the larynx. Local anesthesia of the oropharynx with a xylocaine spray may be helpful or even necessary before this area can be examined. In order to see into the larynx, a laryngeal mirror 20 to 22 millimeters in diameter is needed. This is warmed over the spirit lamp flame in the same way as the postnasal mirror was, and the temperature checked. The patient is asked to open the mouth and put out the tongue and breathe gently in and out through the mouth. The tongue is held with a gauze swab, and the mirror introduced parallel to the tongue and then pushed firmly against the soft palate so as not to excite a gag reflex. We can see the epiglottis, the vallecula, the false chords, and the true vocal cords. The patient is asked to say "ee" so that the movement of the cords can be inspected. Through the cords, the tracheal rings are visible. One should also view the arytenoids and the piriform fossa. During this inspection, note is made of the color of the various structures, any abnormal swellings or ulceration, and of the freedom and symmetry of movement of the vocal cords while the patient phonates. This patient, for instance, has a paralyzed right vocal cord. More commonly, this occurs on the left side, and it is then often due to hilar lung disease involving the recurrent laryngeal nerve. Nodules on the vocal cords or keratotic lesions of the cords, which may be malignant, are other possible abnormalities which should be sought. Any patient who has been hoarse for more than 2 or 3 weeks, or who has complained of dysphagia for the same period of time, should be competently examined by indirect laryngoscopy. If this proves unsatisfactory, direct laryngoscopy under a general anesthetic may be advisable. But this is no substitute for examination with a mirror, which will always provide more information about movements of the vocal cords than can be achieved with a general anesthetic. The next area to be considered is the anterior nares. Thudicum speculum is necessary to examine the interior of the nose, but first, of course, we must look at the external part and the nasal vestibule. The airway is assessed by asking the patient to sniff onto a speculum. A deviated nasal septum may be recognizable from the exterior of the nose. The examination may be assisted by spraying dilute cocaine solution into the nose and observing the degree to which the mucosa constricts. The speculum is then inserted to examine the interior. We can see here the septum, the inferior turbinate as a bulge, and the middle turbinate. The local anesthetic effect of the cocaine solution allows palpation of the mucosa to distinguish between freely mobile polyps and more firmly attached mucosa. Nowadays, nasal obstruction is rarely caused by chronic sinusitis. Much more often it is due to one of the many varieties of vasomotor rhinitis, and these are often aggravated by the injudicious application of nasal decongestant sprays. And a swelling of the cheek is never due to chronic sinusitis. If acute, it most likely arises from dental root infection. If chronic, it may indicate a maxillary sinus neoplasm. Because most malignant tumors of the upper respiratory tract, with the exception of those arising from the paranasal sinuses, may metastasize to the neck, palpation of the neck for abnormal lymph nodes or other masses is also essential. Next, we must consider the ears. Apart from the more obvious reasons, any patient with vertigo or facial paralysis, for whatever apparent reason, must have the ears properly and urgently inspected. First, of course, the external ear is examined. The pinna is inspected for abnormalities and surgical incisions, and then the pinna is drawn upwards and backwards to straighten the external ear canal and an oral speculum inserted. This allows inspection of the meatus and gives a good view of the tympanic membrane, in many ways better than the one achieved with the magnification of an oroscope, since the depth of field is greater and the open speculum allows the insertion of instruments for the removal of wax or the mopping out of secretions and discharge. The light reflex can be seen well here. One should also view the lateral process and the handle of the malleus, the umbo, the pars flaccida, and the pars tensor of the tympanic membrane, and the posterior meatal wall. Perforation of the tympanic membrane, as seen here in the central pars tensor, should be identified. Marginal perforations, including those in the attic, and especially if they show granulation tissue or keratin, are evidence of dangerous disease, as they may indicate bone erosion with a risk of meningitis or of a brain abscess. In order to recognize the presence of a middle ear effusion, the mobility of the tympanic membrane needs to be assessed. This is done with a Siegel speculum, which is attached to the ordinary speculum. When the bulb is squeezed, changes of pressure cause the membrane to move and may suck fluid out of a small perforation. Effusions may not be visually obvious, and an immobile tympanic membrane is often the most useful diagnostic feature, but changes in its color and vascularity may also suggest an effusion. The oroscope, of course, offers the advantage of magnification, and that is useful once a general view has been obtained. It should be held like a pen, and not, as sometimes is seen, like a hammer. And it's held like a pen with one finger extended at the side to protect against too deep penetration into the ear canal. The oroscopic field is much smaller than that of the naked eye. Though useful in general practice, the otologist wanting magnification would usually choose to use a microscope. Finally, of course, hearing must be assessed. Although this requires elaborate audiometric procedures, the correct use of tuning forks for the Rinne and the Weber test still provide the most reliable way of distinguishing between a conductive and a sensory neural hearing loss. It is important to use a fork of 512 Hertz. Higher frequencies decay too rapidly, while low frequencies stimulate vibration sense. In the Rinne test, a comparison is made between the patient's ability to hear by air-conducted sound with a vibrating fork presented to the meatus and bone-conducted sound with the foot of the fork on the mastoid process behind the ear. One can ask the patient, which do you hear better, behind or in front?
In front of you.
A more reliable way of performing the Rinne test and achieving the same aim is to present the stimuli alternately by bone conduction and air conduction until one or other becomes inaudible. Can you still hear that?
No.
Can you hear it there?
Yes,
A demonstration, once again, that the patient is hearing better by air conduction than bone conduction, which of course is the normal state of affairs. Now, in the Weber test, the vibrating fork is placed on the vertex of the skull, and the patient is asked to lateralize or to say in which ear the fork can best be heard.
I can hear it equally in both ears.
Fine. Although these tests distinguish the type of hearing loss, its severity and the identification of the defect require more complex investigations. There are very many reasons for otological referral, and among them, stress should be placed on any patient with a sudden onset of hearing loss in one or both ears. Such a patient should be immediately referred for assessment and for treatment. Now, from what we've seen, it should be clear that examination of the ears, the nose, and throat can be done with a relatively small amount of specialist equipment. But the techniques require a great deal of practice, and the examination must proceed in a formal, comprehensive way. It really is only when the ears, the nose, and throat are seen as a single integrated system that the pathology of any one part can adequately be understood.